the Director of Trauma and Disaster at Parkland Hospital.
Seems like, today's tour, this is the most crowded. It's a lot of people here. Why do you think people are interested?
Well, Parkland's well known for its trauma program. I mean, we've been a trauma center since 1988. Trauma usually is the highest acuity in the hospital. In addition to that, there are many resources that go into a successful trauma program.
Why it is important for you? Usually people cannot see this.
Right.
Usually, but why this is important? You think for people to get to take a look at this?
Well, nobody wants to think that they're hurt or they're ever going to be injured. When you get up in the morning and you brush your teeth, you don't think, oh, by the way, when I'm on my home today, I'm going to have a car crash. But it's one of those resources that if you ever need it or your family needs it, you want to know it's there. And you want to know that it's a very good trauma center. So that's what Parkland's all about. We have been reviewed by the American College of Surgeons every 3 years since 1988, and we have been very successful in those reviews.
Okay. Last question. What is like a typical common questions from your tour?
Most of the questions are, what is the equipment, what's different? So the first thing is the rooms are 1.5 times larger. In addition to that, when this trauma room, the old trauma room was built, there was no computers, right? Then now we have all sorts of things that are technology that we use to manage patients in the trauma setting. And so the room is designed to integrate all of the technology that we have available into the patient's plan of care, into their diagnostic evaluation, and then the interventions as well. And so the other thing that's large is that, it's very large, and the reason is because the trauma team, there are 15 people who respond to the trauma team, from the trauma surgeons, emergency medicine, the trauma nurses, the radiologists, the respiratory therapists, the social work chaplains, and then our trauma psychologists. So the room is large to accommodate all of those individuals, but in addition to that, many of the trauma patients have trauma injuries, orthopedic injuries, neurosurgery injuries, and so it's an integration of all those specialties that makes for great outcomes. And so our goal is excellence in trauma care from the clinical standpoint, but also from the holistic, and be able to manage the patient and the family's psychosocial needs.
Thank you very much. Thank you.
Thank you.
All right. Thank you. Thank you.
I have a question.
Yes.
Is this near where the burn unit will be, or is that something totally different? Or?
We do all the burn resuscitations in this area, and then the burn unit is upstairs. Okay, so we'll do all the burn resuscitation, and they'll go upstairs. And just like if there is, the worst case scenario, if there's a gunshot wound to the heart, I can't fix the heart in this room. So that patient will come through and immediately go upstairs. So it's a very quick response. And so we have different types of responses for different types of injuries.
Thank you.
Thank you. How are you?
Good.
Do I have any questions?
Do you have sort of a standard presentation?
Yes, this is the Level 1 Trauma Center. Parkland is a Level 1 Trauma Center. We've been a trauma center since 1988. This is our highest acuity room. They're all the same. There's 4 rooms set up exactly the same. So what type of patients are we going to put in here? From the worst type of car crashes to the house fire to any type of disaster response. This room is set up for that. It was designed and organized by our trauma surgeons and the trauma nurses. If you look at the carts, the goal was, from a human engineering standpoint, that the individual would not have to make more than 5 steps to get what they need to take care of the trauma patient. So as a patient arrives, we think about airway, breathing, and circulation. So we have the blue cart. If I can't breathe, obviously it's going to be the blue cart. If I have problems because I've lost a lot of blood, then I'm going to get my resources out of the red cart. So the next thing after airway, breathing, and circulation, we want to think about what else might be injured. So we think about x-rays. So you'll see we have digital imaging. And so once they have shot the films or made the films available, they'll come up in the room. They'll come up in this area. And so we can actually, as a team, look at what the patient's injuries are, identify, and create a plan of care. And so from that, we can also explain to the patient. So we can actually tilt that and show the patient, these are the injuries that we've identified. Some patients are going to be too injured and too critical for that. Some will not be, and they want to know what's going on. So once we have done that, then we'll have an idea. We'll have to plan. Does the patient need to go to CT scan? Do they need to go to MRI? Do they need to go to the OR? Where's the next step for this particular patient's care? In addition to that, we are focused on excellence in clinical care, so the clinical outcomes of the patient, but we also are focused on excellence in holistic care. So we want to get the family integrated with the patient's plan of care as quickly as possible as well. And so they can come into the room. We can show them what the injuries are. If the patient is waiting to go to their admit bed, we can move them into the back room, and the family can be with them and stay with them through the entire time. Any questions? In addition, this room can be switched in a disaster mode from a single room to a double occupancy. We can put 2 patients in there. And we need to, we can actually operate in there.